Hi everyone, I'm Dr. Asfandyar Sherani and I'm head of the sub-office Balochistan in Pakistan, and today I'll be sharing few experiences of ours from flood emergency of 22-23 and try to correlate it with module 3 of your course on the operational plan, and module 3 which actually relates with response and prioritization of child and adolescent health needs during emergencies. As already elaborated on coordination and assessment functions under the operational plan, our flood response also had strong foundation in putting in place strong coordination roles and functions mechanisms, and also doing sensitive and timely assessments that actually led to implementation of need-based response during the emergency. Just to give a brief context of this emergency, since we know that it was a flood emergency which rendered 600,000 people displaced from households, and 13% of the health infrastructure was damaged by the devastating effects of the floods. 12 hard-hit districts were targeted in Balochistan, and mostly the districts were inundated and with flood water, and the others were severely affected also. And to come directly to the programming, it must be known to all of us that child and adolescent health programs and interventions are usually dealt under the health and reproductive health clusters. And similarly, there are challenges of overlooking at the adolescent health needs because of the other competing needs and priorities, which may not be true with the child health, but adolescent health area is mostly overlooked by the partners as well as by the stakeholders during any emergency situations. So coming to the module pillars, we see that establishment of services delivery, which is structures, which is given as a first pillar in this module, and it is particularly important in practical work also, because when the emergency set in, the first and foremost thing to decide about was to establish ad hoc structures that would reach to the people that don't have any access, that didn't had any access to a healthcare system. And for that, medical camps, mobile health clinics, and temporary health posts where health facility structure was still viable were the only modalities that we opted for to provide essential health services. And secondary health care hospitals, the structure of them were relatively in place, and which was the reason those hospitals were targeted for strengthening of specialized healthcare services like comprehensive amount services, specialized services for SAM children with complications, and other referral cases. Community health services were also targeted through involvement of community health care workers and deployment of healthcare workers at community level for control and prevention and treatment of communicable diseases and referral of complicated cases. Deciding on the essential services package was another area that was addressed during the emergency planning phase, and health priorities based on the emergency disease surveillance system and other ad hoc sentinel surveillance systems showed that disease outbreak, immunization, nutrition services, childhood development, psychosocial support and mental health support, sexual and reproductive health needs, and WASH were the major areas that were prioritized for essential health services. And it was ensured that in all medical camps and temporary health posts, EPI vaccination, nutrition of under 5 children screening and their referral to CMAM programs, antenatal care services, and family planning were the core areas that were ensured in all medical camps. Apart from that, restoration of services at secondary healthcare level included those to establish and strengthen comprehensive amount services, and then telemedicine services for survivors of gender-based violence cases, and their referral pathways were established and demarcated. Strengthening of healthcare workforce was another area, and capacities of the local healthcare workforce and skilled healthcare workers availability were major issues. Capacity building of healthcare workers was done on customized modules for this emergency, which included RMNCH and mental health, psychosocial support, healthcare response to gender-based violence survivors, nutrition and community-based prevention and treatment of communicable disease were on the priority. After acute phase, WHO strategic packages on PCPNC, labor care guide, essential newborn care and MNCI were targeted, and healthcare providers from the health facilities were trained on these modules. Essential supplies, this was one of the area, and most of the medicines and supplies provided had the considerations around population needs, particularly to reproductive health, maternal newborn child health, nutrition, hygiene kits and clean delivery kits were found to be the most important commodities that were actually needed on ground, and they were supplied. Family planning supplies, particularly focusing on post. About finances, if you look at country office level and as well as sub-national level, all proposal grants that were developed and appeals that were made focused on women and children health, and somehow adolescent health and all those sensitive areas and subtle needs that were obscured in the whole larger picture of maternal and child health programs. And then their sustainability also was a question. So putting all these things in place, it shows that there are large and huge chances of missing on adolescent health needs during emergencies. And during our flood emergencies, a lot had been done to cater to the needs, but somehow a more robust and systematic approach is required to this area so that the adolescent healthcare needs are not missed. I hope this short video has helped you in getting a understanding of the module 3, which is taught during this week. Thank you so much.